Greetings and welcome to this video on enteric fever. This is the part 2 of this video on enteric fever. Where in the part 1 we have discussed about the epidemiology, the clinical features, the diagnostic methods, and the treatment in great detail. It is very much useful for a practicing physician at current scenarios in 2025. So in this module we'll discuss about the advanced clinical pulse and steroid IBD dilemma revolving around the enteric fever. This is completely for educational purposes. This is medicine beyond the Harrison's. Let's get started. So, before diagnosing an enteric fever in the emergency, we look for the pulse rate and we look for the pulse fever dissociation. That is usually 1 degree rise in temperature raises the pulse by 10. So, a patient coming with a fever of 1 or 2, we expect the pulse rate to be more than 120 or 140. But in case of an typical enteric fever, the pulse rate will be low, around 60s to 70s. In that case, it is called as the Fidget sign or the relative bradycardia, which is present in various infections, one of which is enteric fever. So, whether it is always present in enteric fever? No, it is a myth. So, it is not always present. It is seen in less than 40% of the cases that are seen nowadays in the modern era. So, absent does not rule out enteric fever. So we'll go with the day-wise pattern. On the first week, we have the step-ladder pattern of fever, where it usually does not touch the baseline. The fever will go from 100 to 101 to 102 to 103 up to 105, then come down again, increases rapidly, and then come down. There will be bradycardia on the day week one. The second week is the main time when the patients present to the emergency for admission with dehydration, toxic look, leptosplenomegaly, and rose spots. And there is perforation risk in the third week, and in the fourth week, it usually resolves if untreated survivor. It can resolve on its own with adequate macrophage response to the infection. So, atypical presentations when there is persistent fever with no localizing signs for more than 5 to 7 days, suspect enteric fever. When it is normal or low WBC count, suspect viral or enteric fever. When there is low response to empirical antibiotics, suspect enteric fever. When there is a travel history to endemic zone, also suspect enteric fever. So usually the patient with enteric fever presents with fever of high grade with probably a severe headache, unrelenting headache with antipyretics or analgesics. Then dry cough, maybe rose spots in the second week. Classically, if a WBC count is done, it is around 4,000, in the normal range, or even sometimes it can go up to 2,000 to 3,000 with leukopenia and absence of eosinophils that is classically described by the Boyd's textbook. So the Widal trap in most of the scenarios in Indian setups where they inadvertently do a Widal test in the first week, which is not even recommended. It is not used as a basis of diagnosis. Even the Widal test is an serological test usually performed only in the second week. So when a patient comes with a Widal test positive on the first week, always see it with a pinch of salt. It has a high false positive rates. Even with the vaccination and past infections, it can come positive. It also has high false negatives in early disease. So never use it as a sole basis for diagnosis. So Vidal is significant only in when you repeat it after 2 weeks and showing a fourfold rise in the titers. So drug fever versus treatment failure. So expected effervescence time for common antibiotics used. Fluoroquinolones is not commonly used nowadays in India because of extensive fluoroquinolone resistance. Azithromycin is usually 4 to 5 days, and ceftriaxone it is 4 to 7 days. The fever effervescence times, that is initiation of antibiotics to the effervescence of fever. So fever persisting beyond the limit, suspect full compliance, wrong dose, underlying an abscess, MDR, XTR, Salmonella, or any other secondary infection you have to suspect. If the fever goes beyond 7 days in case of ceftriaxone or 5 days in case of azithromycin with adequate dosing. So complications. So you have to always watch for complications on daily morning rounds in case of a patient with enteric fever. The patient complains of sudden abdominal pain, not just discomfort, severe pain. Always suspect operation and go for a CT scan immediately. If the patient is having tachycardia and hypotension, it could probably suggest a GA bleed. The patient becomes confused, delirium in case of an enteric fever, suspect typhoid encephalopathy. Typhoid is also known to cause this typhoid encephalopathy, and also the name of typhoid. The typhoid is itself is known for the delirium. The meaning itself is delirium and a confused state. Delay signs, there can be persistent vomiting in case of ileus or obstruction. There can be severe constipation due to ileocecal inflammation, and the hypertrophy of Peyer's patches may lead to constipation. So, management pearls, always follow this antimicrobial stewardship in case of treatment of enteric fever. It has already become XDR in many regions of the world, especially in Pakistan. So, we can only use azithromycin in that case of XDR Salmonella. So in India, poor usage of ceftriaxone also limit its use to ESBL. Always do a culture before initiation of antibiotics, and once the cultures are obtained, escalate to a narrower oral drug which is susceptible. So hospitalization of enteric fever. Not all enteric fever needs hospitalization. You can treat it as an OPD basis with obtaining a blood culture and starting on antibiotics. So when there is hypotension, dehydration may need hospitalization. If there is persistent vomiting, oral intolerance may require hospitalization. When the patient is toxic or delirious in appearance, may require hospitalization. The patient is pregnant or less than 5 years, or in case of suspected MDR or XDR salmonella. So always look for this carrier state. Keep in mind, you can many of these patients who presented with typhoid in a on retrospective analysis had many of them had gallstones. So gallstones can be one of the risk factor for enteric fever. And also, patients who have recovered of enteric fever may have gallstones, and gallbladder is one of the most common site of colonization of enteric fever, and they constantly keep treating it in the feces. So always, if the person is a cook, always ensure that they are vaccinated or screen food handlers with a stool routine, stool culture, if they are shedding for typhoid or in salmonella. So these kinds of carrier state requires prolonged antibiotics. In case of complete requirement or permanent solution, they may require a cholecystectomy. So enteric fever diagnosis. When the patient is in the emergency, when you want to suspect an enteric fever, in the just the four things that you need to consider is sustained fever for more than 5 to 7 days in the stepladder pattern with no other localizing signs, relative bradycardia for around 60s to 70s, not correlating with the fever pattern, that is fever, pulse, dissociation, and a coated tongue, hepatosplenomegaly, abdominal tenderness is all suggestive of enteric fever. More than or equal to two these signs are present, there is high suspicion of enteric fever. There can be abdominal signs such as abdominal tenderness or hepatosplenomegaly. CBC, mainly there will be normal or low WBC as discussed previously. There can be relative lymphocytosis instead of neutrophil dominance. Eosinophils may be low or even zero in case of enteric fever. So these kinds of patient, obtain the cultures, blood cultures, and then start treatment. So one other important differential diagnosis is considered in clinical scenario where once you do an ultrasound or a CT scan for a patient with enteric fever, there can be at times there will be inflammation of the ileocecal region, which can leads to the confusion of whether it is IBD Crohn's versus enteric fever. So whenever it is fever can be present in both these scenarios. The main differentiating features needs to be considered in ruling out IBD or ruling in enteric fever to appropriately treat the patient. So when in doubt, always give antibiotics and not steroids. So in a case of enteric fever, the fever can be high grade and sustained. In IBD, it is low grade. The onset is acute in within days in case of enteric fever, whereas in IBD it is chronic relapsing with long-standing bloody diarrhea in case of ulcerative colitis, or in case of Crohn's it is long-standing diarrhea, weight loss. In case of enteric fever, it is the constipation that is more predominant than the diarrhea due to hypertrophy of the taste patches. There can be diffuse dull pain in case of enteric fever, whereas in IBD or Crohn's it is crampy pain in the left lower quadrant. Antibiotic response is dramatic within 48 to 72 hours in case of enteric fever, whereas in Crohn's there can be no improvement. Colonoscopy can be done in many unrelenting cases and when you need a perfect diagnosis. In enteric fever, the site of involvement is terminal ileum and cecum, whereas in Crohn's also it is the terminal ileum and cecum. But the difference is, it is in Crohn's it is secretions, cobblestoning, artificial cells and structures that can be present. Whereas in enteric fever, the lesions can be very longitudinal ulcer because of the involvement of the Peyer's patches. There will be edema of the ileocecal valve in case of enteric fever, and rarely there can be pseudomembrane formation. In ulcerative colitis, it is the involvement of the rectum anal canal with continuous involvement and peripheral mucosa. So steroids, never give steroids blindly. That is usually the monocyclide that is used in oral formulation for IBD. Never give it is in case of suspected enteric fever. It can be catastrophic because of suppression of macrophage immunity and aggressive salmonella proliferation and perforation, massive bleed and shock. So there is a very good non-invasive test that can be done in case of suspected IBD versus enteric fever, where the fecal calprotectin can be done, which is a non-invasive inflammatory marker of the gut, produced from the gut macrophages. It's always excreted in the feces, which can be done for the test. If it is the levels are less than 50 is normal. If the levels are less than 200, suspect enteric fever. Wait for the response to antibiotics. If it is more than 500, it has just strong mucosal inflammation and may be likely IBD and go for further evaluation for IBD. So, yeah. So how to avoid errors before steroids? Always do the cultures, check the CBC, fecal calprotectin, imaging for perforation risk and antibiotic responses assessed before giving steroids in case of suspected IBD and enteric fever. If in doubt, always start with antibiotics and not steroids. Wait for 24 to 48 hours for response. If there is improvement, it could be enteric fever. If there is no change or high fecal calprotectin, treat it as IBD. So steroids saves life in IBD, but steroid kill in enteric fever. Rule out infection first before giving steroids. Always use blood culture, calprotectin, and clinical pattern for further assessment and management. Hope you learned something in this enteric fever module. We'll meet with another infectious disease topic. Until then, signing off. This is Medicine Beyond Harrison's. Thank you.